Good evening, everyone, and welcome to PhysioEd. Wishing all my fellow Indians a 75th Happy Independence Day. So, on this fine Sunday evening, I, Dr. Nehal Agarwal, as your host, I'm inviting you for an interactive session on how healthcare systems work with the one and only Dr. Ambarish Akre, sir, who is the founder of and CEO of PhysioEd, and is currently practicing as a physiotherapist at Australia, and Dr. Anuja Butaney, who is currently working in India as a physiotherapist. So, without further ado, let's add our speakers today.
Hi, good evening.
Good evening. Good evening.
How are
I'm
you?
just adding some. I'm fine. Yes. Good evening, sir.
Hello,
Good
sir.
evening, Nehal. Good evening, Anuja. How are you? I think Anuja is ready
I'm
for
good, sir. How are
Independence
you?
Day. You
Happy
are you're
Independence
the
Day to all our
yeah.
viewers.
Every year, happy Independence Day to everyone. And I think amongst the three of us, you are the one who's most ready for it. Looks like looking at your colors.
Very
That's nice,
patriotic,
actually. Absolutely, we have to be all of us wherever we are.
Yes,
Yeah.
yes. So, sir, should we go ahead with the session?
Yeah, we can actually. It's time. I think we have a fair amount of people who have joined us, so I think we can.
Yes.
I think Nehal can take a deep breath. It's all right. Just take a deep breath through the nose and exhale through the mouth. You're all right. You're appearing very conscious. It's not an exam situation. Okay, it's just a casual talk. Yeah, it's an Instagram live. These are our casual conversations. I know it's the first time, maybe a second time for you rather. So yeah, you'll be fine. Yeah.
Are you waiting for people to join in?
Yeah.
All right.
Therefore, I asked, should we go ahead with it? It's
We'll go
25
ahead.
right now.
We'll go
Live
ahead.
people. Okay.
Yeah.
So, sir, today's topic, as we know, is we are going to discuss about how healthcare system works overseas and in India. So now
Yeah.
you yourself have been working in Australia for the past 4 years and have already had an experience for a long time working in
Yeah.
India.
I
So,
did.
sir,
Yeah.
could you tell us the difference between the professional etiquettes which are followed in Australia?
See, there's firstly before we get into this topic, many of the viewers asked me in no personal chat, is this a sort of a comparison of practices? No, it's not a comparison.
No, sir, it is
Yeah,
a comparison.
it's not a
Let us
comparison.
discuss.
It's not a debate. It's not saying that one practice is better than the other. Each one has its own good side and bad side. So when we first talk about the first point, professional etiquettes. Now, etiquettes is one point which has been highlighted of late on a lot of social media on different pages. If you have actually checked, everyone is talking about etiquettes, like in physio etiquettes in medical practice. So we all are aware what is etiquettes. Etiquettes is like how you professionally conduct yourself, or in simple layman's words, we can say code of conduct.
Yes.
So the way you approach a patient, the way you address a patient, the way you make the patient comfortable, because unless the patient is comfortable, he or she is not going to tell you his entire presentation of what he's going through.
Right.
Because we all have studied pain, and like I don't want to get into the definition of pain. I still remember it thoroughly. Okay, given by the WHO. So pain has a physical, psychological, component. And for pain to be assessed properly, for us as physios, whether it's neurological pain or musculoskeletal pain or even chest pain for a cardiorespiratory physio, you need to get comfortable for the patient. The patient should develop the trust in you, which develops in the first 5 minutes when you address a patient. Now, these things are not highlighted in our curriculum back home because I was teaching and I know this was not taught. Okay, so we used to get directly into the chapter. Example, if you're teaching David Maggie assessment for third year, we used to straight away jump into the first chapter assessment and teach the students what is SOAP and what is a structured format, and do observation, palpation, movement, special tests. We do so much special test in ortho. And actually, if you go to see, special test has I used to tell my students past, like, special tests are not special for me. They're not special. They will help you in certain situations, but they can be very if not done properly, they can be very misleading.
Yeah.
So yeah, I don't want to get into that assessment part, because we're not conducting an assessment session of orientation of how to take MSK assessment, which I love to take. But it's more like etiquettes. Yeah, it's more like etiquettes. So unless a patient gets comfortable with you, he's not going to address the pain. So you have to communicate with the patient. So normally what we communicate here is like, we say like, hello, Mr. So-and-so, how are you doing? I'm a physio, and I'll be conducting an assessment on you. I'll be asking you a few questions. Initially, I have some information from the file about you, but I need to confirm that information. So will it be all right if I ask you a few questions? That becomes consent, which is the next point, which we have later. Okay.
Yes.
Following which, the patient gets that confidence in you, and the patient starts telling us like, what all he wants to tell, the psychological aspect of the pain. We finish the subjective assessment, and I'm not going to conduct an assessment here. We later go on to the objective assessment. And before objective assessment, another one point which you're going to mention later today is, I will say, Mr. So-and-so, I will finish the assessment questions, and I'll be going to an objective examination in which I will need to place my hands upon you. Will that be all right? And we say it every day.
Yes.
Suppose I see 30 patients in a day, I say this sentence 30 times in a day. Now, if I ask myself, if I was working in my previous practice, would I say this 30 times in a day? The answer for that is no. I would not have. I would have probably said it if it's a well-esteemed patient, I would have done it. And I accept it if I was working in a general hospital, I would not have asked it. I would have straight away pounced on him, because after him, I have another 50 or 60 patients to address. I don't have time to do all this, that way. So it's not that one practice is good or bad. Sometimes what happens is the time is a factor. And because the Indian population or the Indian setup offers so many patients in a very confined time, that's why you see the etiquettes which we follow are more time bound rather than our actual behavior or professionalism. It's not that we are not professional. In fact, Indians are considered to be the most professional when it comes to any practice across the globe. Whenever you enter another country, and when they come to know that you have done your graduation or post-grads, or when I first time came here, and I said, like, I finished my grads, I finished my postgrads, and I completed 11 years in academics in India. Means, what were you doing? I was teaching as a professor. They were like, oh my God. They were like, they feel like, oh my God, from where these people have come. So that's how the Indians have the name in the international market, whether it's US or Europe or anywhere. So it's not that one practice is bad or good. I think I will keep this confined to this, and I will like Anuja to talk about what she feels etiquettes is in her setup. How does she deal with that?
Yes. So, as I've seen here in my clinical practice of 6 years, it's more patient-centered, and a therapist is always informing the patient, as where you said that you would always ask, if you were touching 30 patients, you would tell them 30 times that I am going to touch you now. It's also the same here when we're exposing patients. We always tell them, like, I'm going to lift up your cloth, or I'm going to expose this area. So likewise, like you were saying, patient consent is very important. At the same time, confidentiality is one of the most important factors, is what I feel, because often there is a breach between therapist or a patient-doctor relationship in itself. The cubicles are not confined, or someone's always eavesdropping, always wanting to hear what's going on with another patient. So those are, I think, the moral code of conduct, like we were talking about, the ethics. So we just need to look into that a little bit. Other than that, I completely agree with what you say.
Yeah, meaning I think it's not about it's not about what we say we are not doing it. It's because the geographical area in which we are practicing sometimes does not allow us to have curtains closed and give the professional confidentiality to the patient, or maybe that space is not allowed, or maybe that time is not there. Whereas overseas, not only, I'm not talking about in this country, overseas anywhere if you go, the geographical factors are more taken care of, because the patient load is less. Basically, the population is not there. So if the population is not there, the patient load is going to be less. Yeah, so it's going to be less, which means the treatment becomes more patient focused. Anyway, we do patient focused treatment anyway. We don't follow a blind format, like this is the way you do it. Because I have said this before in one of the lives. It's like, if you have two patients with low back pain, they may completely present themselves differently. So patient one patient and the other patient might give different treatment, though the MRI findings or the X-ray findings are showing the same changes. So yeah, it is patient centered. That's what I'd say.
So, and ma'am, the points you kept were quite good and agreeable. So, but sir had mentioned something about consent taking, which takes us to the next point.
Yeah.
Ma'am, in our BPT and MPT, we believe that we've been introduced to consent taking
Yes.
for our research process. So, ma'am, could you tell us about the importance of consent taking and what are the procedures which are followed here for consent taking?
Okay, very rightly said. We are always taught to take an informed written consent of the patient, not just verbal, because sometimes it might put you in medical legal issues later on. Also, when it comes to publishing and dissertation and
Yeah.
thesis, like you were saying for the
Yeah.
projects, we are always taught to blind the face or at least the eye areas, so that the identity of the patient is kept safe. So those all are very important factors while considering. Also, as far as the patient is concerned, he or she should know about the harms and the benefits of the treatment, about all the available treatment that's there, all the available options. So yeah, consent of the patient is very important before touching the patient. Some patients are not very friendly. In some religions also, since we have such a wide diversity, they are not okay with a female patient touching a male, like with a male therapist. It's not very likely, or it's not very open like that as of now. So in all those areas, also consent taking is very important. Each and every patient should a verbal as well as written consent should be taken before anything is started. Treatment
I
protocols.
think
So,
I think
what
the
are your
same.
views about it?
Yeah, I think the same thing is followed everywhere. Like, so I'll give an example. Like now we are talking about consent taking when initially starting the treatment, like, we start starting the assessment rather. If I get into the treatment and if you say there's a certain assessment you have completed and you feel that this patient is going to benefit by dry needling, suppose. So obviously back home also and even here, we tell the patient, this is my assessment and I think you're going to benefit from dry needling. So are you all right with us proceeding with it? So many a times, many of the patients are not comfortable with dry needling because they don't know how it's going to react. So then they say, no, I'm not comfortable with needles. I don't like needles. Like here, they don't love needles. So the vaccination rates are very less here. Okay. So that's the reason we are in lockdown for the last 2 months and we are still going to be in lockdown for the next 2 months. Like,
Yeah, we're reading all about it.
yeah, and maybe after a couple of months you will see me tying my hair up and all because we are struggling to get a haircut and get to a basic spa also. Yeah. All right. So when it comes to consent ahead, it will be like if a patient is not ready for dry needling, then we offer the patient, say example, and I'm going to tape up using a rigid tape for you. So even for that, patients sometimes are not comfortable. Like in Australia, patients are not comfortable with taping because there's a lot of incidences of skin cancers here because this is the topical region, as in we are having a lesser amount of ozone layer, so we have more susceptibility of skin cancers here. So taping is also a thing which we constantly require to have a consent from the patient. Like if you develop some allergy, some sort of a itch or a rash, let me know on the next session. Now the
Yes.
difference what happens here in India is in India the patient comes every day no matter what the condition is. So he will come consistently for 4 or 5 days. Here, if it's a MSK practice, the patient comes maximum twice a week, maximum. Okay. So example, if I've seen a session on Monday, mostly your next session is going to be Thursday, or usually it's the next Monday. That's how we space out here in musculoskeletal practices. Whereas in India, we normally have the tendency like you start the patient for 7 days of electrotherapy or exercise therapy continuous, and then we give home exercise programs. So consent taking becomes more important here because if there's a treatment given, we don't have time to react to it. Whereas back home, we have a time to react to it because the next day the patient might come, like usually. Like that's mostly what it happens like. So that's the major difference I feel like what's there.
So, as you said, that consent taking is important while taping the Australian people. But so for that, you need to have good communication skills, right? So
Right,
what?
right.
So what is the importance of communication skills, and how have the overseas practitioners been trained to effectively communicate with their patients?
Well, it's. I think we all teach it. Like even we used to teach it back home, like when we were in acads. But obviously, what used to happen is we have such a big curriculum back home in the Indian setup. No matter which university you're doing a bachelor's or master's, you have so many hours of clinical, postings. You have a dissertation club, you have a journal club, you have other presentation, you have UG teaching to do. You have Saturday afternoon. You come here in overseas setup. They come to uni 2 times or 3 times a week.
Yes.
3 times a week is what they come. They spend around maybe 2 hours in a week or 3 hours in a week doing patient handling. And that too, they don't handle the patient here. They're not allowed to handle the patient directly. They do it under supervision. And the rest of the time, they have maybe 2 or 3 hours online curriculum or maybe some journal club or some curriculum. You see, most of even your batchmates or your seniors, you must be knowing, when they go overseas, they say it's a comparatively a very sort of a relaxed atmosphere. Obviously, there are different stresses of a different magnitude. So example, the way you conduct yourself in the professional way, or now you're talking about communication skills. So communication skills is really emphasized here. Like even when we came here from overseas, like overseas physios, we are told that we know how you practice back home, but that's not the way we will do it here. For us, the autonomy of the patient is most important. It is all patient centric. So you have to basically, the patient should be happy what you're doing, whatever treatment program you're designing, the patient-centric treatment should be given, for which the patient communication skills becomes really important. So addressing the patient, respecting the privacy of the patient, making sure that you are taking care of the dignity of the patient. So example, like Anuja mentioned some time back, is like, using permission to touch the patient, or even the dignity of the patient. And many times, like we are, like I'm coming to the next point is goal setting. So in goal setting, we all follow back home in India also what we follow is the SMART goals, like, specific, measurable, they should be achievable, they must be realistic, and they should be time bound. So when you're doing
Yes.
all these SMART goals, many times happens that the patient gives you very unrealistic goals here. For example, he's come with a knee injury, like, 1 week back, and his short-term goal is I want to go and play a game of footy next week. Now,
Next
I
week.
can't see you next week. Yeah, that's what they say. Make
Okay.
me play a game. I have a game of footy next week. I have to go and play that because this is a sports bound nation. They don't listen. They want to get back immediately. They
Right.
are into sports. They are into sports. Like you see, all the Olympic swimming medals have come here. So they just jump into the water here, no matter what happens. So when they are actually told to give a short-term goal, their goals are very, very, broad. Like in India, what we'll say, if I had my patient, they would say, "हाँ, कोई बात नहीं, मुझे 10 दिन का, like, give me a certificate. Like I'll stay at home, I'll take rest." Like, whereas here they are so aggressive, they want to get, realistic. They don't frame realistic goals. So when it comes to goal setting, whether it's doing it in terms of like your smart format or in terms of your treatment which you're going to give, you should basically make sure that you are taking your communication skills into account so that you convince the patient. तो ऐसा नहीं होना चाहिए. You should not be saying that no, your goals are useless. That's not the right goal. I'm going to tell you what your goal is. That you cannot say that. You have to convince the patient is I understand that getting back to the footy field is so important for you because that is your passion. But how is it like if you feel that if you play only one game and if you again enjoy yourself, that might put you off the entire season. That
Yes.
would be really devastating, isn't it? So how
Yes.
about you miss this game next week and we focus on the game which is after 3 weeks, and then the patient says, "Oh yes, I feel you're talking right."
Makes
So
sense.
this is,
Yeah.
yeah, this is communication. So this is not buttering. I'm saying this is communication. You have to communicate your assessment, or you have to communicate your goal setting to the patient in such a way that he feels that yes, what I was setting is wrong and what my physio is saying is right. So that's why whatever assessment you do or even goal setting you do, it entirely boils down to how you communicate it to your patient. Like because I think we have said it before in a few sessions, and I think even you guys practice it back home. Is the first 5 minutes or 10 minutes of your first day with the patient? Okay, you might not get the patient for you forever. Like he might not become your patient forever. But if you do something wrong, he will definitely make sure he won't come next time to you, no matter what you do the rest of the session. So you cannot
True.
make a patient in the first 5-10 minutes, but you can break a patient by a communication skills. If the patient doesn't develop the confidence in you, he's not going to come to you for the second session, and he's going to fire the patient outside that this person who is here, he or she, I'm not too confident, he was a bit struggling or she was struggling. So make sure you find somebody better. Like so, you won't make a patient, but you will break a patient by communication, faulty communication.
Mm-hmm.
So, ma'am, sir has talked about the communication skills and goal settings. But in India, we follow the clinical documentation rules. So, as a physiotherapist in the hospital also, and as a home therapist, physiotherapist also, we document each and everything. So, what is the importance of clinical documentation, and how does it help us to become better, or how does it help us in the future way if we are giving a handover to any other physio?
Yes.
Could you
Nehal,
elaborate
before
on it?
I address clinical documentation, I would just like to go back to what Sir was saying and add a few points that I feel are important. So I feel that when you're communicating with a patient, as we said, it's an integral part. It's really important to communicate in a language that he or she understands.
Yeah.
So even while we're taking the history, even with me, when I was in my bachelor's, since it was a task, speaking in Marathi or even understanding what the patient is saying, I remember my university exams were such a nightmare because the patient used to tell me their history in Marathi, and I
Yeah.
couldn't, translate and put it down. And like they would just say like Pishwi Kadli, like something in gynae. And I would have to
Yeah.
go and see what that even means or what surgical procedure has been done.
Done.
And not having the files around, that is a completely different ball game altogether.
Yeah.
And yeah, so getting back, I'm trying to say that communicate with the patient in a language that he or she understands, and make sure they understand what you're doing, and more importantly, why you're doing it. So the goal settings that we were talking about, all the electrotherapy treatments benefit in some or the other way, but
Yeah.
their mechanism of action, their working is very different. The physiological process is different. So to explain it in patient terms, they are not going to understand pain gate pathway, when you explain them tense. They're not going to understand A delta and C fibers and all these fancy scientific terms. So we need to be and speak in layman terms, and yeah, just get to them on their level, and make sure and be confident that your treatment is going to work. Because unless you believe the treatment is going to work, I don't think they're going to believe,
Exactly.
like the confidence
Yeah.
that we were talking about. Yeah,
Before
and
Nehal comes to
the
the next question, I'll just add
yeah.
on to what Anuja said is in terms of documentation, no, in terms of documentation, you said is like not using medical words. So we call them medical jargons. So you're not
Yeah.
supposed to use medical jargons when you're communicating with the patient. So when they conduct assessments for students overseas, if you use a lot of medical jargons, you might be marked negative.
Oh,
You lose marks. Yeah, you lose marks if you
yeah.
use words flexion extension. If you use any surgical procedure, you lose marks
Mhm.
because you're supposed to say, okay, now you can lie down. What is happening is this aspect in the front of your thigh. This
Right.
muscle is important. You're not going to say
Right.
quadriceps or something there. Front of
Right.
your thigh, backside of your lower leg. You're not going to say
Mm.
calf or any scientific
Mm.
gastrosoleus. If you use
Mm.
words which are flexion extension, movements, if you use something like spasticity when you're mentioning to a patient, neurological patient, that this is the clonus or this is spasticity, you lose marks. You're supposed to say this is a sort of a tightening of a muscle, which will relax slowly. So can you relax, 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 and the patient will relax. So I did send a few videos from the University of Macquarie on the physio ed groups. Many of people who are here will be aware. So that is for training the neurological patients. So if you see the communication skills between the therapist and the patients in those videos, you get a fair idea of how different it is. Like treatment is the same. We all do the same treatment. In fact, many times I think we do sophisticated treatment in India. It's very high advanced. Yeah, we do it, but we make it look better because we communicate it, or the patient understands things better because the actual addressing is given more emphasis here, which we don't give. So yeah, I mean that's important.
Yes.
Okay, coming back to the clinical documentation. So could you elaborate on the importance of clinical documentation?
Okay. Clinical documentation as a therapist and as a patient is very important. Say after 5 to 6 days, or even if you talk about overseas, after you've seen the patient alternate days or like servicing once in 2 weeks, sorry, twice in a week. When the
Yeah,
patient goes home, you need to give them their discharge card or the exercises they need to do at home, like the home protocol, like we call it. So
yeah,
documenting the progress of the patient is very important in terms of range of motion, in terms of strength. So these aspects need to be checked every day, and they need to
yeah,
be documented also every day.
yeah,
Moreover, the sets and the reps also are very important because you could change. I mean, it could be you could train an individual for strength, or you could train an individual for endurance. In that way, your entire protocol will be different. So they need to understand why are we giving those particular reps or those particular sets. Also, it helps to know over time. It's just a way to compare, like over time, how much progress has been done by the patient.
yeah.
So even he gets a positive feedback, and I think that's very
Feedback.
important because when someone is recovering, they need that positive feedback. Again, going back to communication skills, like we were talking, the positive feedback also comes, we always write down in our goal setting, short-term, long-term goals, patient education, patient
Mm.
counseling.
It is.
So
Yeah,
there, like Sir was saying, the first 5 minutes can even break a patient. So if you don't make him believe that it's gonna work, it's not probably not gonna work, because once it's set in their head, the placebo
yeah,
treatment, ये नहीं
yeah,
काम करेगा. If
yeah.
he or she believes so, it's not gonna work.
It's not
So I
exactly.
think that's why clinical documentation has its importance. So what do you feel?
I'll just add it in simple. I think we all do it. So basically, documentation we do it in terms of say a SOAP format, subjective
Mm-hmm.
objective assessment on planning, which we all follow, all of us everywhere in the world. And the other format which I'm sure you guys have also used is called as isobar.
Mm-hmm.
So isobar is like we do identification of the situation, observation, background, assessment, and the risk factors. So we basically document it in those words. We identify the issue, we observe the patient presentation, we document it. Okay, we check the background of what the patient is coming from, like whether it's a social history or whether it's any other pre-morbid condition which the patient had. Then we conduct an assessment of what you found out from the subjective and objective assessment there.
Right.
Then we do what is called as the assessment and action, and then we do a recommendation. Or what we see is we identify the risk. For example, you might have 10 tools in your armory, but all those 10 you cannot take them out at one time. You can only take out 2 or 3 tools at one time. So what other tools are at risk is the patient might not be comfortable. You should keep them away. You can't take off everything at one time. So risk identification is important. And the last thing is you have to recommend the patient what is right. So how it becomes like a home program, like this is what's right for you. And this is that's why we say giving a home exercise program which is written is really important. And it should be explained. It should not be pamphlets sold in the market. Like many times I've seen that happen back home. They just give pamphlets.
Yes.
Many medical practitioners or doctors, they feel physio is not required. What I can do is I can just print it on a piece of paper. Like these are the exercises and my patient will do it. No, that's not going to work because the patient has not understood it. Because you yourself don't know the exercises. The medical practitioner, that's not his
Also,
domain. Yeah. Go on, Anuja.
sorry. No, please go ahead. Sorry.
No. Go on. It's all right.
No, also it's very generalized, the pamphlets that you were talking about, They're
Yeah.
not specific, they're not tailor-made.
No, they're not tailor-made.
Yeah, so, yeah.
So it's not only even if they were tailor-made for the condition, still you're going to is not going to be there because the patient is not understanding what he or she is doing. So you see they're doing quadriceps drill or they're doing hamstring drills, but they're doing so many compensatory movements of lumbar spine, pelvis. So those are not
Right.
going to work out. So it has to be physio-specific. That's where one major difference, which I always point out when I come in such sort of sessions, is I know physio practice in India is changing and now it's becoming direct referrals, but still a bulk of the Indian physio practice is coming through referrals, believe it or not.
Yep.
Patients are still going through a surgeon or through a neurophysician or to an MD or a gynac and then coming to us. Whereas in overseas, a patient directly comes to the rehab. So here, what they say, the patient is theirs. The physio can proudly say that it's my patient. Whereas in India, like many times, I know there'll be many people here who might listen to this and not agree with me because they'll say, in my setup, my patients come to me. They don't come through a surgeon, which happens in a lot of cases that people who are practicing their setups and have established a base, patients come to them directly. But I'm talking of a basic setup here, back home. It is all referral based so far, and I think it's still referral based. So that has to change, and it will change over a period of next few years, I feel. Yeah, I'll allow Nehal to go ahead. He's looking at the time, I think.
Yes, I agree to the points which you mentioned, but sir, due to the shortage of time, I think we'll have to end the live session. And thank you, Dr. Ambarish, and thank you, Dr. Anuja, for participating in this interactive session. And I hope that many of us can pick up the points and use it in our day-to-day lives while treating our patients and help the community grow more further, be it overseas or be it India. So thank you. And lastly, thank you to the audience who were a part of this interactive session today. Thank you.
Thank you. See you
Thank
next
you.
time.
Thank you.
Yes, take care, bye.
Take care, bye-bye.
Bye-bye.
Yeah.